He's written 6 books and published numerous psychological publications. He continues to write, see patients, and supervise professionals treating chronic patients in the United States and Europe. Dr. McCullough has been married to Rosemary Fleming McCullough for 60 years, and they have 3 adult children and live in Henrico, Virginia. And just by way of introduction, Dr. McCullough gave grand rounds in April, and he focused then on early onset persistent depressive disorder as a manifestation of abuse and neglect, which halts the developmental trajectory in a pre-operational state. And this state, in this state, the person with persistent depressive disorder is unable to understand rational cause and effect. And Dr. McCullough highlighted that CBASP, the psychotherapy for chronic depression, utilizes a unique degree of interpersonal investment and companioning on the part of the therapist in order to break through patient isolation and serve as a platform for learning interpersonal skills. And since many of these skills need to be learned from scratch, an effective course of CBASP tends to run much longer than a typical course of CBT or IPT or other brief psychotherapy models. And so today, Dr. McCullough is going to focus in on some of the main techniques of CBASP, including something called the interpersonal discrimination exercise and situational analysis. So with that, I'll pass the baton over to Dr. McCullough. Jim, the floor is yours.
Thanks, Brant. Delighted to be with you all once again. And going to try to take you to a place you may not have been before. So let's see what happens. I'm going to share the screen and get into all right. You all know about the little view in the upper part of your screen and how you can expand that. So I'll move on. I think today is September the 29th, 2023. And again, it's good to be with you. By way of a little review, as Brant said, CBASP is an interpersonal model of psychotherapy. I've been very influenced by Mr. Interpersonal Psychotherapy, Donald J. Kiesler, for a number of years. He and I spent a lot of time together for about 25 years at Virginia Commonwealth University. And the interpersonal model is a two-way interactional model, which in the beginning with the chronic patient is really a one-way model because there's not a lot of give and take between therapist and patient. But CBASP is an interpersonal model of psychotherapy. And interestingly enough, which I hope will become really clear today, it's based on an acquisition learning training. I want to teach the patient to do some things they have never been able to do before. And I'm going to make an assumption. If you learn what I want to teach you here, you will overthrow the chronic depressive dilemma. And you see this little graph, and these graphs are very familiar to all of you all, with the abscissa, the horizontal line representing really no learning goes on, and the ordinate, the vertical line, going from no learning to maximum learning. And I should have said the abscissa is really a time dimension from first session to how many ever sessions you have. And then the ordinate represents the amount of learning that goes on. And I've put in a nice learning curve. And make a stringent assumption: if the patient doesn't change the way they think and behave, they stay depressed. No change? No change in depression. And I make that in a gentle way, clear as I can to the individual at the beginning of treatment. So we're not talking about you're just feeling better. We're talking about you're learning some things to manage a chronic condition. You want to talk about other chronic depressions, high blood pressure, diabetes. It's difficult to cure high blood pressure or get rid of diabetes 1 and 2, and it's difficult to cure chronic depression. But I can teach patients to manage it, and manage it very well. Considerable research has been done with kids during an early developmental period. And we have substantial information that severe trauma has the possibility to inhibit maturational development in the cognitive emotional arena. Inhibit. It can derail cognitive emotional maturational growth, to say another way. And we call this maturational stunting. For the early onset adult patient, you see this going on in middle schools or junior high schools to some of you. And it seems to be a lifelong condition that doesn't remit with age and consigns chronic depressive kids to move into adulthood functioning in what we call a preoperational manner as adults. Now, I will define in a moment what preoperational function is. It comes from Jean Piaget's second stage of development, and I'm not rigidly adhering to Piaget's stages, but his descriptors for preoperational development, which occurs between about 3.5 and about 7 or 8 years of age, really describes the early onset chronic adult. Describes it better than any category I have run across. There are all kinds of severe traumas. There's physical abuse. There's sexual abuse. There's emotional abuse, where kids are subjected to demeaning comments and labels. There's emotional deprivation, where parents simply don't deliver warmth and nurture and expressions of love. It's just not present in the home. Or it can be physical deprivation. There's nothing in the pantry, or not enough warm clothes, or I don't have any shoes to wear. Emotional deprivation, very prevalent. in the reports of early onset chronically depressed adults. And then there's a category called psychological insults, where severe, intense, demeaning comments are made over the long haul of growing up. You're nothing. You never will be anything. You can't do anything. You're a failure. You're a poor expression of a human being. And on and on and on and on. Psychological insults, which take a horrific toll on the individual and begin to interfere with growth. Now, I gotta say that not only do these types of trauma interfere with cognitive emotional maturation, or can growth, we've got good evidence that severe abuse and severe continual stress can inhibit physiological growth. In fact, rural pediatricians very quickly see a child who has a physical body or chronological age of 12 or 13, but who has a physical body that has grown to be about 9 or 10. And they quickly recognize this child is in a stressful home environment. And they take these kids out, and by gum, these kids begin to grow again. So we've got good evidence that severe trauma not only can inhibit maturational growth in the cognitive emotive area, but also in the physiological area. Preoperational functioning, which comes from Jean Piaget. From about 3.5 to about 7.5 years of age. The individual is extremely egocentric, self-centered. Chronic patients, me, myself, and I, dominate the landscape. They cannot generate empathic functioning, as I mentioned before when I was talking to you and your colleagues. Empathy requires abstractive thought. And a preoperational child or a preoperational behaving adult cannot engage in abstractive thought in the cognitive emotive area. Now, I want to note that this has nothing to do with IQ. I've treated some very brilliant people who can almost work higher order math in their head, but you put them with people and they're little boys and girls. Pre-operational functioning, these people talk in a monologue fashion. They tell you the same story they told your receptionist, they've told the grocer, they've told the dentist, they've told everybody who would listen. It's just a repetitive sameness, and it's a monologue. They talk at, they don't talk with. They think in pre-logical, pre-causal ways. Reality is the way it is because I believe it to be. And if you really look at the dynamics of chronicity, time is involved. These patients have no future. The way things are is the way they've been and the way they always will be. It's like I'm living without a future. Now, you immediately can think about what you're going to do tonight, what you're going to do tomorrow, and this kind of thing. Not so with a chronic patient. There is a sameness that characterizes their functioning. And they are absolutely deficit when it comes to problem solving. They think in global ways. The adverbs, always, never. The qualifiers, perhaps, maybe. The definiteness is not there. And they have absolutely learned or never learned to problem solve their difficulties. So the sameness just reverberates. It's like moving around in a circle over time. Now, to give you an example of how a normal IQ, pre-operational functioning adult who reported severe childhood abuse, but thinking in a pre-logical, pre-causal manner. Show you how this is exhibited when she describes what happened to her at a picnic. Now you say, this is kid stuff. Yes, it is. But this was a 35-year-old lady, not psychotic. I went to a picnic Saturday afternoon. What happened? Well, I wanted to get my picture taken, but the photographer wouldn't take it. Mary, Phyllis, and Susan got their pictures taken. Therapist asked, did you ask the photographer to take your picture? No, I just knew that he wouldn't want to take my picture, so I didn't ask. And you and I think, huh? But this is the way they live, which means you sit with somebody who is not cognitively and emotively functioning the way you are. You got somebody different in your therapy room. And I did this the last time I was with you all. This is who you got in your therapy room. This is a preschool chair. I don't know how many of you have sat in a preschool chair recently, but you got an adult who in some significant ways doesn't function the way you do. And that's one of the toughest lessons I have in teaching individuals how to treat chronically depressed patients. I face a dilemma when I begin treatment. If I have somebody who's really different than I am, doesn't think like I do, doesn't emote the way I do, this little drawing shows the patient within a on the other side of a wall. And my responses are bouncing off of that wall. And that's exactly what happens at the beginning of treatment. If you are not influenced by others, And if you orbit in a world of sameness, then the environment cannot get to you, influence you, mold you. And that's the dilemma of chronic depression or persistent depressive disorder. The environment can't get in. Therapists in the beginning can't get in. And nothing changes. Nothing changes. I think this is the core issue you face. And the environment can inform or influence the behavior that hits you in the face during the early sessions. Your task is to interpersonally connect this person with their world. That's what you got to do. They come in detached, withdrawn, and your goal is to connect them first with you and then with others. Which implicates a piece of CBASP, which I think is its most novel component, and that is the relationship between therapist and patient, which I've described as disciplined personal involvement. And I learned it just the way you do. You do not get personally involved with patients. But with someone who never had a relationship, I was faced with, how in the world, Jim, are you going to teach this person to relate as a human being if they've never learned it before? And I had to come up with a different interpersonal model for the therapist. And it is very different. Now, I want to show you a brief video clip, about 5 minutes, of two normal pre-operational children to give you an idea of what pre-operational functioning looks like. Now, these two girls are a little over 3.5. They're fraternal twins. They're my granddaughters. And I wanted to see if I could construct an activity that might illustrate what pre-operational functioning looks like. And that's what I'm going to try to show you today. What Jean Piaget was talking about when he talked about pre-operational functioning of children. Okay, I'm gonna have to, by the way, this is a little marble game activity where marbles roll down chutes, and you'll see how it's done, but it gives me a chance to interact with these two little girls. And I've got to say, this is 16 and a half, 17 years later. They're both seniors in high school. Today is their birthday. And they're 18 years old. And they're bright as they can be. So what we're looking at now is not what we would look at today if we could see them. Okay, let me share the screen and see if I can present this to you, and I really hope you can hear this.
Okay.
All right, here we go.
Oh, you stopped it. I see.
Can you see this, Eric?
How does this stop this?
Oh, this does.
Huh?
It does.
It just does?
There's a rubber with it. So
Oh, okay.
I put it over.
But why does this stop this? Do you know?
I don't know.
You don't know? Okay.
Take a picture of me.
Yeah. Here's one over here. You got two twins again. Now you got a green one, a green one.
Why is this sticky?
Yes. You've got Allie and you got Lizzie.
Stop. Go in here.
Why does it go down here? Do you know?
No.
Don't know. You're not sure? Why does it roll down here?
I don't know.
Do you know, Allie?
I don't know. There.
Don't know. Okay, who's gonna pull it?
Oh,
Oh, okay. You get the turn next time.
go.
All right. Now, what do you gotta do to get that unstopped? You know what you gotta do? No, you can't push it. What do you have to do, Allie? Little finger, you remember? And where do you put your little finger to get this stuff? Can you put it inside there? Try. Inside there. That's good. Okay, can you put your little finger inside here and push up?
Okay.
You have to kind of turn your hand around. Now, push it up. Can you do that?
No.
Well, it's kind of hard to get to it. You're getting there. You let one. Let's see if you can get any more. Oh, you got two. Can you get any more?
There's no more.
I think there is. It's still stuck, silly. Put your finger in here. What in the world is... Oh! All right. Allie, you don't have your cast on where you broke your arm.
Oh, I think we can put this
Sure you can. How you want to do that?
right.
And what is that going to do to the marbles?
Just
Huh?
boom.
What's it going to do?
I don't know.
You don't know?
Let's see.
Well, I want to ask you something. Where is your cast on your arm? The cast is home? The cast is on a washing machine. Well, why don't you have your cast on your arm?
She does it.
Why not?
Because
'Cause what?
it's time to take I already got it off.
You just got it off. Is your arm okay?
Hey guys, you can hear this.
Yeah.
Well, I started out. I started out to ask them some questions about causal observations. Why did a marble roll down a chute? Or what would happen if you put a block in one of the chutes? What would happen to the marbles? I don't know. I don't know. And then we went through a little problem solving exercise, trying to get Lizzie to get her finger up to unblock the marbles which had locked up in the chute. And you begin to see that the twins' preoperational behavior, very self-centered. They're not talking to each other. It's a pre-causal, pre-logical kinds of mentation or thinking, and they're not able to think abstractly. And a lot of their talk is monologue talk. They would answer my questions, but it was very monologue overall. Now, I'm going to suggest something to you. We can take a primitive thinking adult patient who's functioning in a pre-operational way, and I can present a treatment for them to learn, and the treatment can be presented in an abstract level way. And if the environment is safe for them, by gum, they can learn the methodology, and they can begin to function on a higher cognitive emotive level. Let me say that again. I can take a primitive functioning adult preoperational chronic patient, and I can teach them some methodologies to solve problems and to relate to me and others. And I can present it on an abstract level, and they can master it if the environment is a safe environment. And they begin to maturate again. In short, they begin to grow up. Now, Jean Piaget and his students have really demonstrated this with a number of children who were abused as kids, and presenting something at a higher intellectual level, like abstract functioning versus pre-operational functioning. Individuals who feel safe can begin to maturate and will begin to reach an adult level or abstractive level of functioning. It's kind of crazy, but they've demonstrated it over and over again, and this is the essence of CBASP. We present on a much higher level intellectually than they come in on, but we do it at their pace and in a safe environment. And by gum, they begin to mature. Okay, let me share the screen again, and I'm going to . let me talk about two major CBASP techniques. And the first is the interpersonal discrimination exercise. It's 4 steps. 4 steps. And patients learn these steps and can do it without any prompts from the therapist. And what's the goal of the interpersonal discrimination exercise? It's to teach them to discriminate between adults who have hurt them and the person of the therapist. Now, I found out if you don't do this in psychotherapy, chances are your patients are not going to do it. So I make very clear that patients learn to discriminate me from people who've hurt them. And they are able to do this in an environment of dyadic safety. And as they begin to discriminate, when you think about this, it requires abstractive thinking. It's looking at this and looking at that and telling the difference. That's abstract thinking. That's a highly mature level of thinking. And I teach them, what was it like when you were in this situation with your father or with your mother? Versus, what was it like when you went through this situation with me? And then I ask them, what are the similarities and what are the differences in the way they responded and the way I responded? And if I turn out to be different from significant others who've hurt you, what are the possibilities for you in this relationship? And that's a high level of mentation. That's abstract thinking. Versus, nobody likes me, I can never do anything right, I'm always going to fail, I'm no good, blah, 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 blah. And now I'm able to take a look at externals and make a distinction between them. And I do this through a therapist's role called disciplined personal involvement. I inject myself right into the middle of their self-centeredness. What is it like to go through this situation of, say, disclosing something you had done wrong with me? With me. I just jump right in to the middle of the self-centeredness or the egocentrism. And they begin to make discriminations. And in the beginning, they're not aware of who I am, what I do. All they know is themselves and what's going on between their 2 ears. The other thing I've learned is patients really can't learn if they're afraid, and fear in the relationship interferes with good learning. And if you'll think back to the video clip, in many respects, I'm a teaching comrade, much like I was with Lizzie and Allie. Right in there, I'm not on the floor, but right in there with the patient. jumping right into the middle of the egocentricity and teaching them to discriminate me from significant others who've hurt the patient. That's the interpersonal discrimination exercise. The second exercise is situational analysis. It's a problem-solving task. It's 5 steps. And patients get to be able to do this on their own with no help from me. Now, when they come in, nothing goes right, all is wrong, no one likes me, I can't do anything right, I always fail. And then I teach them to focus on one situational event that occurred between them and another human being. Just one. So they got to stop their usual presentation of themselves and they got to look at a situation, and it's very difficult for them to stop and look. But we got time. And I ask them what happened in the situation. And the first step to this 5-step exercise is they pinpoint a problem situation. That's the road to abstract thinking. Looking outside yourself at something that's ongoing out there. Remember, I said, I'm presenting a task that requires higher level thinking than pre-operational function. So they lay out a situation. It has a beginning, a middle part, and an ending to the story. And the story ends with a behavioral ending. I got to have an ending that I can see or hear. That's abstract functioning. They got to translate their communication into something I could see or hear. It's amazing. Second task. How'd you interpret the situation? And I'm very different than CBT therapists because interpretations for me mean reading what is going on right now between me and another person. It's not a dysfunctional belief. It's not a problematical attitude. It's what's happening right now. What are the interpretations? Nobody likes me. I always fail. I'm really feeling terrible now. Has nothing to do with what's going on right now. And I've got to teach them over time how to capture what's happening in the interaction between you and another person. That's the beginning of empathy. I can read the other person. It's also abstracted thought. Third, how did you behave in the situation? I'm looking for the patient to tell me what they did. First, they're going to learn how to understand and interpret what's actually going on, and then they're going to learn how to behave. But in the beginning, their behavior is, well, I didn't make eye contact. I looked at the floor. I looked at the ceiling. I walked out of the room, and on and on. But gradually, their behavior becomes very targeted to what's going on. Focusing on the other person. and you see the beginning roots of abstractive thinking. I'm thinking about something else outside of myself. Then, how did it end up? Consequences for an interaction. Now, we often tell patients, that's very good, you did well. That's not your strongest reinforcer. Your strongest reinforcer that you've got is whatever stops their pain. And I want them to take a look at the consequences for their behavior. And if they put in maladaptive cognitions and if they behave badly, then the actual outcome is probably not going to be very good. And that's okay. Because the fifth step is, how would you like to have had that situation come out for you? Now listen to that. What's a better desired outcome than the one you got? Here again, requires abstractive thought to formulate it, and it's a very difficult task for most beginning chronic patients. Do they get their desired outcomes? Not very often in the beginning. We go back through situational analysis and teach them how to fix and repair badly managed situations, how to think in a crisp, focused way, how to behave in an appropriate manner, and how to get what they want. It's kind of hard to stay depressed when you're getting what you want most of the time. I briefly mentioned a dissertation study that I supervised and recently in the last year. We did what we call a dismantling design. We took the two main treatments of CBASP, situational analysis and interpersonal discrimination exercise. One group got just essay. One group got just interpersonal discrimination. And then a third group got the whole model put together. And we used Janet Williams up at New York State Psychiatric Institute, who has operationalized a beautiful, it comes from the Hamilton Depression Scale, PSI-D. And we used her instrument as an outcome, as the primary outcome measure in the study. These were means of the subjects in the SA cell alone, which was the X's. Means of the subjects in the IDE only cell, which was the squares. And then the combination treatment where patients got the whole model. And this is what it looks like. The interpersonal discrimination exercise brought down depression a little, and then it plateaued. When comparing it with situational analysis, it had a greater effect as patients learned to cope. And then the effect continued on during the last half of the study. And then when we administered the whole study, we almost had parallel results at the midpoint between the combination cell and the SA cell. Combination cell certainly came out better than SA. But it looks like that situational analysis had a more desirable effect on depression intensity with the PSI-D. And it also, we did this with the BDI, and it mirrored what we got with the PSI-D almost exactly. It looks like problem solving is really critical for these patients. But we also had some effect with interpersonal discrimination. It's this relationship that's so important. And set the stage for depression decrease. These are the norms down here on Janet's PSI-D. And our assumption is this: it will be difficult to remain depressed if you learn this interpersonal discrimination exercise, the criterion, and essay the criterion, and you learn how to apply both in daily living. And hopefully we've moved very primitive thinkers to a higher level of cognitive emotive functioning. Now, I've taken you all very quickly over a lot of territory, and I'm going to stop this, and we don't have a lot of time for questions, but if we've got any questions, I'll certainly entertain them now.
Thanks, Jim. Folks, feel free to unmute and just speak up your questions, or you can also put them in the chat function.
Yeah.
Well, hi, I'm Debbie Delmore. I don't really have a question. I wanted to thank you for this talk. I am very intrigued by what you're talking about. It made sense to me, and it was very stimulating. Thank you. And I was also really, really pleased to see your grandchildren in the video, because that it really crystallized the concepts you're talking about. So thank you. Very stimulating.
Thanks for the feedback. That's very helpful. Very helpful.
Yeah, folks, please just go ahead and unmute and speak up, or write your questions into the chat function.
Are there any other resources on CBASP you'd recommend? Yes. I would start with my website, and if you have got a pencil and paper, I'll give you my website. It's www. all capitals CBASP. .org. And what you've got, though I haven't gotten to revising this website, and it needs revision. What you've got are a number of books I've written, and they're about 50 or 60 journal articles that you can take a look at if you're interested. So I give you more than you ever bargained for. What I would suggest, if you pick up a book, I would pick up my 2015 book from Routledge. It is CBASP as a distinctive treatment for persistent depressive disorder. CBASP is a distinctive treatment for persistent depressive disorder. It's about 135 pages. Doesn't take you that long and to read it, and you'll get a good overview of what the model's all about.
Jim, there are a couple more questions in the chat. One from the Ward 7 residents at the VA here. First off, they say, happy birthday to your granddaughters. Then,
We're going to do that later on tonight. Okay.
They say they're curious if you have any knowledge of the role of substance use in the stagnation of development.
I'm not sure I understood that question, Brent.
Yeah, I think they're wondering if so say, for example, you have a person with early onset chronic depression and they have substance use as part of their developmental picture. How does that affect their developmental trajectory?
I don't know how to answer that question, but certainly it affects it. This substance use is a tough one, particularly somebody who's actively addicted to substances during treatment. And I'm afraid I've never been able to if I can't get people off substances, there's not a heck of a lot I can do with them otherwise. Here's a question. I noticed that interpersonal emphasizes conscious learning about the difference between therapists versus the unconscious transference of emotions. Very briefly and quickly, I think Freud asked a little bit too much of patients. I'm very explicit. Rather than a patient understanding their transference to the therapist. We have a way in situational analysis of making this very tangible. I see how I behave with this person, this person, this person, and I can do an essay on me and the patient. I see how I behave with McCullough. So not only am I getting insight, I'm getting behavioral observations about the way I relate to other people. Now, Freud didn't have access to learning theory and to what I've had access 100 years after Freud, but my stuff is extremely explicit. And I want people to see, to feel, to touch, to grasp not only the baloney that they produce, but also the people who reap this stuff, what they're doing to other people. And then when the change comes, they see the beauty of what they do to other people. And it becomes very explicit. I don't understand how psychotherapy has lasted as long as it does. All auditory. The most inefficient medium of learning there is. Auditory. And you will forget 90% of what I said within 30 minutes after this grand rounds is over. And I know that. When I talk, well, Brant asked me. Inefficient. But you got eyes, you got taste, you got feel, you got all kind of other sense modalities that you really need in learning. And yet in psychotherapy, we talk and we talk and we talk. If you want to get humble, ask a patient what you talked about last week. I don't know. Why the hell do we do it? Well, we all do it. I do it. I don't know, but I try to do some other things in addition. Brad, we're out of time. I got all afternoon, so I don't have to go anywhere.
Folks are welcome to stay on.
If you
you'd
want
like
to stay on and
the
talk,
conversation.
stay on and talk.
Yeah, and feel free to sign off too if you need to. There was a question from Marsden Livingston asking, does CBASP have efficacy in treatment of PTSD since it seems trauma can be a component of persistent depressive disorder?
Very good question. If you've got a person with an active PTSD, nightmares, flashbacks that are disruptive, I would tone that down first before I administered CBASP. And I do. It's hard. It interferes with learning anything. If I've got flashbacks, I can't learn. If I've got these haunting dreams that I'm afraid to go to sleep with, I can't learn anything new. So you need to tone this anxiety, extreme anxiety reaction down. And then when it quiets down, then we can do CBASP, but not together. It's too much. Too much. Okay.
Dr. Livingston shared that, thank you, that makes a lot of sense. Other questions for Dr. McCullough?
If we're in the middle of talk time, why don't you, and it's okay if you want to hang around, why don't you put yourself on video and talk to me and ask me, and that'd probably be better for me to be sure I can answer your questions directly.
Spoken like a true interpersonal therapist, Jim.
I guess it is.
Yeah, Jim, I was just curious about why you think the because there's a study that suggests that the average course of CBASP goes for I think it's like 33 sessions or 34 sessions to elicit an effect. And why do you suppose it takes that long relative to, say, other models of psychotherapy?
I was chronically depressed as a younger man. I came out of a developmental circus, zoo, whatever you call it. And I said earlier to you that I've really come to the conclusion you never cure the depressive dilemma. It's always there, and the reason is the hurts are always there. I just think you've got emotional hurts that are so difficult. I have to say this. I really grew up feeling like I never had a father and I never had a mother. And I've spent a lot of my life not gathering fathers and mothers, but encountering a few from whom I have learned how to be a human being, both guys and gals. I married a gal who has probably had the biggest impact on me. In fact, in January, we will have been married 60 years. Hadn't it been for her, I might not have been alive today. But anyway, I just think this stuff is bad. And why does it take so long? It's tough to learn how to manage this stuff. And you never get rid of the memories and the hurts. They're always there. People, and I'm 86 years old. People will be in a group that I will be in a group with people, and they're talking about beautiful memories of their families. I usually get very quiet and don't say anything. I think two things. You don't know how lucky you are And the second thing I think is ouch. Never had that. And you don't ever make up for that. But I do pretty well in spite of it.
Thank you, Jim.
Takes a while.
Yeah.
Any other comments? God, I wish we could sit around in a group and just talk about this stuff. I really, this is really meaningful to me. I like to do this. I like to do this.
Jim, thank you so much for tuning in here and sharing this stuff with us.
You bet. Thank you for inviting me. Hope it's been helpful to you. Just everything about CBASP is stuff that I've kind of lived through. So
yeah. Well, if folks have further questions, please feel free to, you can reach out to Jim.
absolutely.
And we can share his email. You can reach out to me as well if you want to touch base with somebody within the department, or send me a Tiger Connect message if you have questions about the modality or its application. And so yeah, thank you, everybody.
All right, gang. Best wishes to all of you all. Bye-bye.
Take care, Jim.